Hello everybody and welcome back to my YouTube channel. I'm Iana Simova and you are watching Cardiology for You. This is the channel about physicians, about cardiologists, about medical students, about other medical specialists, about patients, about healthy people. So you could find here anything that could be of interest to you, starting from healthy lifestyle to differential diagnosis in different clinical situations. This time I have chosen to talk about a topic because maybe it would be some of the last videos in this year in 2019, and I would like to talk a little bit about the left atrium and what was new and what was old in the evaluation of this chamber in the year 2019. Before we get started with this video, please make sure that you are subscribed to my YouTube channel and that you have clicked on this ring bell button down there. This is the only way that you will get notified when I'm posting a new video. So, if you are interested in seeing and watching what is new about the left atrium in the last year, then please keep on watching. In this video, I am going to talk about several things. The first thing is a little bit about the function of the left atrium, then about the volumetric analysis of the left atrium. Then comes the strain of the left atrium, and here we have new things that are very important, and last but not least a couple of slides about the meaning, the usefulness of measuring of left atrial volume index during stress echocardiography. So let us start with the function of the left atrium. Left atrium has many physiological functions. It secretes natriuretic peptides and communicates with the RAS pathway. It modulates the LV filling, contributing to around 30% of the cardiac output. It is a useful prognostic biomarker in cardiovascular disease, and also it acts as a barometer of the diastolic function of the heart and the left ventricle. If we are strictly speaking about the hemodynamic role of the left atrium, then it could be divided to three main parts. The first is the reservoir function, that is during the systole of the heart, and then come two other functions, the conduit and the booster function during the diastole of the heart. A typical example and a proof that left atrium acts as a barometer of diastolic function is that the volume of the left atrium is included in the algorithm in determining if a patient has or has not a diastolic dysfunction, and also it serves to determine which is the degree of this diastolic dysfunction. So, that was enough about left atrial function. Let us now move to the volumetric analysis of the left atrium. Here, dear friends, there are three most important volumes that should be measured about the left atrium in order to calculate, evaluate the volumetric function of the left atrium. These volumes are, of course, the maximal volume of the left atrium. This happens just before the mitral valve opens, so it is at the end systole. Another very important volume is the minimal left atrial volume. It happens, of course, when the volume is at its lowest stage, and this is when the left atrium has emptied all its it has to be emptied in the left ventricle, and this happens in end diastole. Another very important volume of the left atrium is the one that gives us the function, the pump function of the left atrium. This is before the contraction of the left atrium, and it is called the pre-A volume, the volume that we could measure just before the P wave on the ECG, before the contraction of the left atrium. And having measured these three volumes, we could determine the changes in the volumes during a cardiac cycle. As you could see in this figure, we have an increase in left atrial volume, which is calculated as left atrial expansion volume. This happens during a systole, and it happens from the minimal to the maximal left atrial volume. Then during diastole, we have an emptying of the left atrium, which is at first passive emptying during the diastasis, and then active emptying during the pump function in sinus rhythm, of course, of the left atrium. So we have the passive emptying volume and the active emptying volume. And having said this, we could derive some functional indices of the left atrium. One of the most important is this one, the total left atrial emptying fraction. It is the difference between the maximal and the minimal left atrial volumes divided by the maximal left atrial volume, the same way as the ejection fraction of the left ventricle is calculated. Another very important functional parameter is the conduit 1 on the left atrial passive emptying volume. It is measured as the difference between the maximal and the pre-P or pre-A left atrial volume divided by the maximal left atrial volume. And the other very useful functional parameter is the pump function or the active left atrial emptying volume, which is measured as the difference between the left atrial volume just before the P wave or the A wave, or from the mitral inflow, so the pre-P left atrial volume minus the minimal left atrial volume and divided to the pre-P left atrial volume. Of course, we have normal values. These are the standard normal values for the maximal left atrial volume. You know that they are the same for men and for women, and the upper limit of normal is 34 milliliters per square meter. We speak about a mild impairment of left atrial maximal volume when we have this volume in the range between 35 and 41. Then we speak about a moderate impairment when we have this volume between 42 and 48, and of severe impairment when we have this volume over 48. Another useful way to measure the volumes of the left atrium is to use 3D echocardiography. Here we could measure very easily all the useful volumes of the left atrium, and also we could measure the segmental volumes of the left atrium. Why we need 3D to measure more exactly the left atrial volume? Because, dear friends, the axis on which the left ventricle and the left atrium lie, they are not parallel to each other, they are not on the same axis. You see there is a slight angle between them, and if you have the perfect apical four-chamber view for the left ventricle, then for sure you are cutting the left atrium, because you pass somewhere here and not from the maximal longitudinal axis of the left atrium. If you want to see the maximal volume and diameters of the left atrium, you have to search for them in some non-standard left ventricle views, and you could almost never be sure that you have found just the maximal left atrial volume. That's why we need sometimes 3D measurement of left atrial volumes. Let us now see what is the meaning of these functional parameters. This is a very nice example, a very nice study about the left atrial emptying fraction. This is part of the MESA study. It contains a large number of participants, nearly 2,400, free of atrial fibrillation. In these patients, the investigators have measured the volume and function of the left atrium with CMR at baseline, and then 5 years later, and even more 5 years later, so 10 years from the beginning with CMR. So this is a very exact measurement. During this period, 142 participants developed atrial fibrillation, and the authors have found that an annual decrease of even 1 standard deviation unit in the total left atrial emptying fraction was most strongly associated with risk of atrial fibrillation after adjusting for all clinical factors, for AF baseline, left atrial parameters, and LV mass to volume ratio. This is a very, very important finding. Another very useful study, like the last study, it is again from this year, so very new, very contemporary study. This is the study about the left atrial functional index as a predictor of cardioembolic stroke. In this study, we have nearly 100 consecutive ischemic stroke patients. 10% of them had large artery atherosclerosis. 41% had this cardioembolic stroke that we are investigating mostly. 2% have small vessel disease, another 2% have other kind of strokes, and 45% have ischemic stroke of undetermined etiology. This left atrial functional index was assessed by the following equation: left atrial emptying fraction multiplied by LVOT VTI and divided by the left atrial and systolic volume index. And the authors have found that both maximal and minimal left atrial volumes were larger in those patients with cardioembolic strokes than the non-cardioembolic patients. And also they have found that the functional indexes were lower, and this left atrial functional index was very informative, and a value less than 0.3 was an independent predictor of cardioembolic stroke. And yet another very interesting and important study to show you, this is again very, very new study from the year 2019, to show you that not only large volumes of the left atrium, but also the small volumes have their prognostic significance. This is a large study, more than 17,000 patients, all of them in hospital patients. Small left atrial volumes were defined with a volume less than 16 millimeters per square meter. Then, within the normal range limits, the authors divided this whole group to two subgroups, like low normal from 16 to 25 milliliters per square meter and high normal from 25 to 34 milliliters per square meter. Then we have a large left atrial volume index and very large left atrial volume index more than 45 milliliters per square meter. Patients were followed up for a long time. The median was 2.4 years. It is very interesting to see what are the underlying causes, the etiologies of this small left atrius. So the most common thing was a decreased intravascular volume resulting from dehydration, third space separation, anemia, bleeding, etc. Another important group was those patients with pulmonary hypertension or other significant lung disease. Also, right ventricular failure, pericardial effusion, and so on. And, dear friends, you could see this clear U-shaped relationships. Here the author find that for every milliliter per square meter of the volume of the left atrial, which is below the high normal, not just the low cutoff point, there is a 10% increase in the in-hospital mortality and 8% increase in the all-hospital mortality. So I think this is really a very important finding from the new data about the left atrium from this year. And now we come to LA strain. And here, my dear friends, I'm very happy to say that now we have finally a standardization, and this is done by the EACVI, AC, and the industry in this document about the standardization of left atrial, right ventricle, and right atrial strain. So now we're going to talk about just the left atrial and about determining the ROI and tracing the LA wall. It is said that the strain should be measured in a non-foreshortened apical four-chamber view of the left atrium. That left atrium is contoured, extrapolating across the pulmonary veins and the orifice of the left atrial appendage. Also, it is very important, once the ROI has been defined, the user should always be offered a moving display on which she or he can visually check the quality of the tracking and adjust whenever necessary. And of course, if available, a dedicated mode should be used. To the question which of the strain parameters should be used, the myocardial deformation of the left atrium should be assessed by global longitudinal strain. Which imaging views should be used? GOS of the left atrium should be calculated as the longitudinal strain obtained from a non-foreshortened apical four-chamber view. The B-plane left atrial longitudinal strain, taking into account the measurements from four and two-chamber views, should also be available as an option. So, very important about the definition of end diastole and the onset of atrial contraction. These should be defined according to the mitral inflow pattern, because the ECG, the R and the P waves in the ECG can only be used as a rough estimates. Sometimes the curve of the left atrial strain with its typical morphology could serve itself as a sufficient guide for the end diastole and the onset of atrial contraction, and you could see this in the next slide. So you see that the onset of systole and the end of diastole is determined by the mitral valve closure and not by the beginning of the QRS complex, which is not so precise, and also the contraction, the last phase of the deformation of the left atrium during diastole is better determined by the onset of the A wave than by the onset of the P wave on the ECG, which is not so exact. Also, of course, if you have a good strain curve, you could see very well where the strain curve becomes from negative to positive and changes its direction, so you can determine these very useful time points. Another important thing to say here is that the LA global longitudinal strain should be given separately for the reservoir, the conduit, and the contraction phase. Very important thing is the reference frame of the zero strain. There are two distinct options with respect to which reference frame should be set to zero strain, and choosing one or the other option may affect the strain measurements. If we choose the zero strain reference at LV and diastole, then we have only a positive left atrial strain during systole. But if we choose the zero strain reference at the onset of the LA contraction, then we have first a negative deflection of the strain, and the strain it starts to increase, but it's still negative at the onset of systole, and it gets positive but reaches not so higher values as here you could see. So what does the task force recommend? It recommends that ventricle and diastole is the time reference to define the zero baseline for left atrial strain curves. All other reference zero lines should be definitely set that have been used, and the values should be recalculated to this kind of reference line. So I would like to share with you now a very recent manuscript that has been accepted but not yet published in the International Journal of Cardiology. It is a study of our collaborative group, the FLASH Multicenter study, and the aim of this study was to investigate the correlation between the left atrial function assessed by spectral tracking echo and the quality of life assessed by the Minnesota Living with Heart Failure questionnaire in patients with chronic heart failure. So we included stable heart failure outpatients, 369 from 7 different international centers who underwent echo studies. Patient over 75 and with AF were excluded. LA strain was determined by spectral tracking echo by averaging the 6 atrial segments, and the size of the left atrium was assessed using the B-plane volume and 4-chamber area acquisition. So we found a very strong correlation, very statistically significant, between the left atrial strain and the Minnesota Living with Heart Failure Questionnaire total score. We still find a correlation, but not so significant, less significant, between the Minnesota Living with Heart Failure Questionnaire and left atrial volume and global longitudinal strain of the left ventricle. And we were not able to find, we have found no significant correlation between the score of the Minnesota Living with Heart Failure Questionnaire and the LV ejection fraction, and also E to E prime ratio, E to A, and also E to A ratio. So when we performed a ROC analysis, it turned out that among all of the echocardiographic parameters analyzed, left atrial strain presented the highest diagnostic accuracy with an area under the curve of 0.74 in predicting a poor quality of life. So our conclusions were that the FLASH study examined the correlation between left atrial structure and function and quality of life in heart failure patients by speckle tracking echocardiography. The strain of the left atrium resulted to be very strongly inversely correlated with the quality of life. On the other hand, there was only a weak correlation between the quality of life and the volume of the left atrium and the global longitudinal strain of the left ventricle, and no correlation was demonstrated either between quality of life and LV ejection fraction, or between quality of life and E to E prime and E to A ratios. Finally, speckle tracking echo confirmed to be a good non-invasive tool for the evaluation of atrial dysfunction, whose clinical impact must be proven yet. In reference to our study result, left atrial strain could be an echocardiographic parameter strongly correlated with heart failure patients' self-evaluated quality of life, and for this reason, and also because it is a non-invasive and well-accessible method, it might be integrated in the current serial evaluation of chronic heart failure patients, this way adding to the current decision-making process. So another useful study, again from the year 2019, which analyzes the strain of the left atrium, is this diastologic study. It is about the function of the left atrium and left atrial strain as the measure to differentiate between the very early stages of diastolic dysfunction. And as you could see in this figure, the stages of diastolic dysfunction have been divided in an early stage 1 and late stage 1 diastolic dysfunction. And you could see that the only parameter that distinguishes the early from the late stage 1 of the diastolic dysfunction is namely the strain of the left atrium. All other parameters are equal. Also, I would like to share with you that the strain of the left atrium is very strongly correlated with the severity of the fibrosis of the left atrium. This is an inverse correlation, and it is very nicely demonstrated in this MRI study with the figure representing two patients, one with almost no fibrosis and a very high strain curve, and the other with a large area of fibrosis and very diminished and flat strain curve. And so it is not surprising that this kind of structural remodeling of the left atrium by MRI could predict the recurrence of AF after cardioversion or after ablation better than the type of the atrial fibrillation. You could see that either in patients with lone AF or with patients with non-lone AF, the rate of AF recurrence depends mainly on the classification of fibrosis in the left atrium. And I would also like to share with you a very recent study presented this year at the ESC Congress in Paris, and this is about a healthy group, 400 healthy volunteers who were followed up for 16 years. And the primary endpoint was the development of atrial fibrillation, the secondary, the development of atrial fibrillation and ischemic stroke. And the authors measured the strain of the left atrium, and you could see that there are different terciles of the strain of the left atrium, which largely determine the risk of AF and of stroke in these patients. And as you could see, the left atrial volume index, LEVI, is also a predictor of AF and of stroke, but when the strain of the left atrium is added to LEVI, it has its incremental value, and every 5% decrease in the strain of the left atrium leads to a 30% increase in the risk for development of atrial fibrillation and ischemic stroke. And last but not least, I would like to share with you our initial experience with measuring of left atrial volume index, or LEVI, during stress echo. So this is a poster that we presented at the last year UREC Imaging Congress, and we have the following reasoning that an enlarged LEVI at rest mirrors increased left atrial pressure and or impairment of left atrial function, and it is associated with adverse cardiovascular outcomes. A cardiovascular stress test may acutely modify LEVI within minutes, and we aim to assess the feasibility of LEVI stress echocardiography. So, stress echo was performed in 171 patients at a mean age of 58. They had coronary artery disease, heart failure, or hypertrophic cardiomyopathy. All had acceptable acoustic windows and stress, and the stress echo modalities that we have used were mostly exercise stress echo, then dobutamine, dipyridamole, and just a single case with adenosine. So left atrial volume index, or LEVI, was measured with the Simpson biplane method from 4 and 2 chamber views at rest and at peak stress, and the percent LEVI change was defined as the stress minus rest divided to rest values and then multiplied by 100. So LEVI measurements was obtained in all patients, and the feasibility was 100%. The offline analysis time measured by a stop clock in 40 patients was less than 50 seconds. The intra- and inter-rater variability was very low, about 6 and 8%. However, LAVI was unchanged during stress echo in our group. However, there were 13% of our patients that we defined as LAVI dilators, dilating the left atrium with more than 25%. Another 13% were LAVI reducers, reducing their LAVI volume by more than 25%. So these LAVI dilators were equally present in exercise or pharmacological stress, but they were more frequent in patients with coronary artery disease compared to heart failure or hypertrophic cardiomyopathy disease. Also, when we measured systolic pulmonary artery pressure, we found a correlation between SPAP and rest and stress LAVI. So our conclusions for now were from this very new and first and innovative LAVI stress echo study were that LAVI measurement is highly feasible during stress echo, that it requires no extra imaging and very limited extra analysis time. LAVI is correlated to SPAP, but no single and homogeneous LAVI response can be identified during stress. A spectrum of variations occur from a marked increase to a marked decrease, and these likely mirror the underlying stress-induced variations in LA function and or pressure of potential clinical relevance. So, my dear friends, the take-home messages from this presentation about the new and old things of the left atrium in the year 2019 are as follows. LA is a chamber with multiple physiologic functions. LA functions and volumes could serve as a predictor of AF, cardioembolic stroke, and prognosis. Not only larger, but also smaller in-hospital LA volumes are associated with worse prognosis. Regarding LA strain, now we have standardization. GOS is the preferred method from non-foreshortened apical 4-chamber view, and diastole and the onset of atrial contraction should be defined according to the mitral valve inflow profile. LA global longitudinal stress is reported separately for the reservoir, conduit, and contraction phase, and ventricular and diastole is recommended as the time reference to define the zero baseline for LA strain curves. LA strain correlates more strongly with heart failure patients' self-evaluated quality of life compared to LAVI and left ventricular GOS. Left atrial strain is a more sensitive biomarker for the early stages of LV diastolic dysfunction compared to LAVI, and also left atrial strain could predict both incident AF and ischemic stroke in the general population, again better than LAVI. This was all I have intended to share with you this time. As I have said, maybe this would be one of the last videos that I'm going to post this year. So I would like to wish all of you a very happy, very cheerful holiday season, and hope to see you soon with new videos on cardiology for you, my YouTube channel.